Good evening, Dr. Gite.
Good evening, sir. Good evening, sir.
Good evening. कैसे हैं? All fine?
Yeah, yes, sir.
आज का केस है थोड़ा डिफरेंट टाइप का है. So I thought के it
Yes,
is
sir.
different than other cases what we have done earlier. और आपकी राय क्या है? This time you were examiner in Delhi. So
Yeah, just near about 1 month before I went to RNR.
हाँ.
There are one long case, two short cases, and two ward round, and two table viva, which includes instruments, specimen, X-ray, research methodology, and subspecialty. These are the.
Okay. So in subspecialty,
So during table viva, subspecialty means what I have asked in exam is during last 3 years what in which subspecialty we have got interest, and in that first subspecialty that's what I have.
Okay.
There is no any guidelines about what to ask in subspecialty.
Oh. So
Another is research methodology. In that the type of research, then types of articles like case report, case series, meta analysis, original article, then studies may retrospective, prospective study, randomized control, non-randomized control, uncontrolled, blind, ये जो type of studies है, इसके लिए भी एक टेबल है, अभी एक सेक्शन है, अभी DNB से लिख के आ रहा है कि उसमें पूछना है.
Oh, okay. So this time OSCE was not there.
OSCE was not this.
But the students were also very less.
Students, first day 3 students and second day 3 students. Out of second day 3, only one appear. So in 2 days 4 appears.
But is there any indication that OSCE will be there this time or it will not be there?
Sir, as far as DNB is concerned, there is no any indication like that. This OSCE is not there only for this term. It will be there for next term. I suppose लिख नहीं आया.
Okay.
But for different others, they have used OSCE. That's what I heard from few people.
Yeah. So what we will do, we'll have a case discussion, but now we will, instead of going too much in detail, we will finish it a little faster, and then in between we'll take even OSCE also, so that students are prepared for Viva. OSCE means ultimately it will be like a Viva, so they will be prepared for that.
Yes, sir. So I bet preparation should be in depth for long case, and investigation and treatment oriented for short case, and definitely importance is given to the ward round also, because someone CR will present the case and examiner will ask the questions during that presentation. That's what we have followed in that last exam.
Yeah, Pankaj has joined. Good evening, Pankaj.
Good evening, everyone.
Good evening, sir. Good evening, sir.
Good news,
Good evening, sir.
that Pankaj has become now head of the department and has got 2 students. It's
Yes, sir.
good news for even the next step, whoever wishes to join DNB Urology, one of the good teacher and a good unit you will have.
Luckily, we have really got very good students this time.
Yes.
So and it's a very different experience. Both of you have gone through it to have your own student. This is the first time for me. It's a very different experience and a very enjoyable experience.
Yes.
Yes.
I can see on your face.
Have I started looking old?
No, I'll tell you, with the students, we became more juvenile.
Yes.
Because of good interaction and their enthusiasm and their knowledge makes us younger in our thinking also many a times.
True.
I think it's a good experience, and even your work will be shared, and they will be of great help to you.
Absolutely.
And you are believing in research, and you are doing lots of research papers and all. you and your students, I think they will really benefit.
Thank you, sir. Thank you. Really looking forward to this experience.
Yes. So now we have got 36 participants. I think we can start now.
Yes, sir.
Huh? Okay. Fine. So we have got our first year student Paras, who is going to present this case.
Hello.
So if in case this is his first presentation, Paras, this is your first presentation, correct?
Yes, sir. Yes, sir.
Yeah. So in case if he makes any mistake or if there are any shortcomings, you can just tell us, or you can tell him, and from the next time we will improvise on that. Okay, Paras, go ahead.
Myself, Dr. Paras, welcoming you in Clinic for PG Updates. Good evening, respected teachers, my dear colleagues. Today's case discussion is on topic large vesicle calculus with bladder outlet obstruction.
Who are going to answer?
Sir, I am Dr. Abhishek Ghosh from Jaslok Hospital.
Yes.
I'll be answering today, sir.
And second?
Sir, I am Dr. Amit from Jaslok Hospital.
Okay, Amit and Abhishek.
Abhishek is always ready.
Yes, he is always ready.
Good. It's good.
Thank you, sir.
Okay. Fine. Okay, Paras, start reading.
Starting with the case, presenting a case of 65-year-old Hindu gentleman, resident of Mumbai, retired, presented with the chief complaints of difficulty in passing urine from 1 year, dribbling of urine from 1 month.
Paras, I think you need to share your screen.
He is already, I can see his screen.
Yeah.
Yes, sir. I can
Please,
answer.
presentation.
Yes, sir. We are able
Okay,
to
you're
see
getting
that,
it?
sir.
ठीक है.
Yes, sir.
Okay, I've got it. Sorry, it was my mistake. Go ahead, please.
With the chief complaints of difficulty in passing urine from 1 year, dribbling of urine from 1 month, blood in urine from 3 days, fever from 3 days, generalized weakness and drowsiness from 2 days.
Yeah. So Abhishek, this is a history. How you are going to elaborate? What are the important questions you will ask?
Yes, sir. I'll like to elaborate each and single complaint in detail, sir. And sir, first of all, difficulty in passing urine since 1 year. He has quite a long history, sir. I would like to know that what difficulty is he having in passing urine? Is he having any associated? What is the onset, duration, and the progress of the complaint, sir? Was it associated with any complaint, any associated instrumentation, or what kind of symptoms are there, sir? Voiding or storage symptoms, sir. What is the severity? What is the degree of bother of those symptoms, sir? I would like to know. And what is the current? How bothered is he with the current symptoms right now, sir? That I would want to know, sir. Then, sir, dribbling of urine, sir. I would know. I would like to know, sir, whether the dribbling of urine is intermittent, continuous. How much is the amount? I mean, for dribbling, what is he doing? Is he using pads, or what is he? If he's using pads, then how many pads are getting soaked in 24 hours, sir? Is there any time of dryness in between? If it is intermittent, what is the time of dryness, sir? And is there any associated LUTS associated with the dribbling, sir? As far as blood in urine is concerned, sir, I would want to know what is the onset, duration, and the progress again, sir. And first of all, sir, whether the hematuria is painful or painless hematuria, sir. Whether, it is said that it is associated with fever, sir. Then I would ask, sir, the hematuria associated with LUTS or not? Sir, is it associated with any clots or not? If associated, then what is the shape of the clot, sir? And then, sir, then moving on, sir, painful, painless hematuria, yes, sir. And then any history of instrumentation, any history of medication, sir, any history of if similar episode in the past, hematuria, sir, whether it is intermittent or continuous, terminal, mid, or initial, sir, that character I would want to know, sir. And fever, sir, fever associated with hematuria, it is, sir. So, sir, is there any history of burning micturition associated with it, sir? Any lower urinary tract symptoms, sir? And sir, generalized weakness and drowsiness since 2 days he's telling, sir. I would want to know, sir, how was he before this, sir? What was it sudden? Was it like was it insidious, sir? How was the drowsiness? How drowsy is he throughout the day, sir? This I would want to know, sir.
Fine. So Paras is there, na?
Yeah, yes.
Paras, you want to ask anything else?
Next slide, sir.
Aditya has asked, he has said about the medicine. So which are the drugs you want to know about?
Sir, with concern to blood in the urine, I would like to know that the patient is on any anticoagulant medication or not, sir, aspirin or warfarin, sir, anything. And as far as generalized weakness or drowsiness is concerned, sir, I would want to know whether he's on any antihypertensive or not, any anti-diabetic or not, any anti-diabetic for any comorbidities or not, sir. These drugs I would like to ask, sir.
Why do you want to know about antiplatelet or anticoagulant drugs?
Sir, so anticoagulants, sir, medication may be associated with hematuria, sir, mucosal. Sir, the patient may be having some bladder pathology, which and bleeding may be caused because of that pathology, which will be aggravated because of anticoagulant medication, sir.
Yes. So this thing should be very clear that drugs alone can never cause hematuria. They only increase the hematuria.
Yes, sir.
What other drugs would you be interested in taking into consideration all his history?
Is he taking any antipsychotic drug or antidepressant drug?
How will that impact?
If overdose of that drug can lead to drowsiness.
Okay. Any drugs which increase the urinary difficulty? His urinary difficulty has increased in the last 1 month.
Yes.
Yeah, which drug?
Alpha agonists can increase urinary difficulty, sir.
Okay. Are they
Tricyclic antidepressants or selective serotonin reuptake inhibitors, or all these can cause difficulty in.
So the commoner drugs which will increase and especially cause dribbling of urine would be smooth muscle relaxants like bronchodilators. Maybe he has been started on some diuretic, we do not know. So if somebody was already having bladder outlet obstruction and now put on diuretic for some other reason, that can significantly increase his lower urinary tract symptoms.
Yes, sir.
Okay, proceed please.
Yeah, Paras, go ahead.
History of present illness. History was given by patient's son as patient was drowsy at the time of admission and seems to be reliable. According to him, patient was asymptomatic 1 year back when he started developing difficulty in urination. Frequency of grade 4, urgency present of grade 3, nocturia is 3, intermittency is 3, weak stream is 3, straining present is of grade 2, incomplete emptying is 2, the IPSS score is 20/35, and the bothersome effect affecting the quality of life to urinary symptom is 4. That is moderately dissatisfied due to these symptoms. Patient also complains of continuous dribbling of urine since 1 month. There are episodes of normal urination in between. Patient is using diapers for continuous dribbling. It is also associated with LUTS as described previously, and it was not associated with any stress. Patient also gave history of passage of blood in urine since 3 days, which was incomplete, present at the terminal part of urination, associated with suprapubic pain, passage of amorphous shaped clots, and was associated with burning during urination. Patient also have history of fever since 3 days associated with chills, relieved on medication. Pattern could not be commented as there was no documentation. Patient also have generalized weakness, lethargy, and drowsiness since 2 days, which was not associated with any focal neurological deficit, seizure, activity, or headache.
Fine.
Coming,
Abhishek, yeah, go ahead.
coming to the negative history, there is no history of nausea, vomiting, or flank pain, no history of bleeding disorder, any blood transfusion, or any anticoagulant therapy, no history of swelling in the lower limbs or facial puffiness, no history of lower limb weakness, trauma to spine or spinal surgery, no history of recurrent urinary tract infection or perurethral discharge, no history of urethral instrumentation or recent catheterization, no history of episode of acute retention of urine, no history of yellowish discoloration of eye and urine, backache, headache, or respiratory distress, no history of loss of weight and appetite in recent past.
Yeah. So Paras, history is over.
Yeah,
Okay.
past history, comorbidities, and medication. Patient is on alpha blocker Tavurimax 0.4 mg since 1 year for the lower urinary tract symptoms. Patient is also a known case of non-insulin dependent diabetes mellitus and is on oral hypoglycemic drug. There is history of open left ureterolithotomy 20 years back, during which patient had an iatrogenic intestinal perforation, which was managed by explorative laparotomy and a colostomy, for which a restoration was done later. Patient had a burst abdomen at the time of recovery, which was managed conservatively by dressing, leading to a large abdominal defect, which was closed by secondary intention. Patient also have 2 episodes of subacute intestinal obstruction 2 years and 6 months back, which were managed by conservative medical management. There is no history of hypertension, ischemic heart disease, pulmonary tuberculosis, hypo and hyperthyroidism. Personal history: patient is vegetarian by diet, non-smoker, non-tobacco chewer, and non-alcoholic. Bowel habits are normal and regular. Sleep is disturbed due to nocturia. No known allergy to any food or drug. Family history is nothing contributory. This much
Yeah.
is history.
So Abhishek, after
Yes, sir.
listening this all things, so what are the probable possibilities? Because this patient had widening lower urinary tract symptoms followed by dribbling, which is associated with fever and with history of some bowel surgery in the past. That time probably they may have done a catheterization. So there are 4 5 diagnoses of associated diabetes. So it is
Yes, sir.
more or less bladder outlet obstruction secondary to the benign oblique malignant enlargement of prostate.
Prostate. Yes.
It may be associated with or without bladder stone because pain and fever.
Previous history of
Again, it may be associated with neurogenic bladder.
yes, sir.
Then probably he may have stricture urethra post catheterization. So these are the probable expected diagnosis you may encounter after examination and investigation.
Yes, sir.
So any other diagnosis in your mind?
So bladder mass
Bla
causing obstruction to outflow.
Bladder mass, if it is bladder mass, then he had only recent history of hematuria only for 2 to 3 days. So there are less chances of bladder mass because the sequence is like widening symptoms, dribbling. That means obstruction. Probably he may have retention, overflow, incontinence. We don't know. After examination, we will rule out it is a full bladder or empty bladder. Then he has history of diabetes. Again, one of the predisposing factor for retention.
yes, sir.
And he may have a history of catheter. He had history of catheterization. So again, additional, he may have stricture. And patient had a suprapubic pain and hematuria. So that bladder outlet obstruction may be associated with stone. Then he had some bowel surgery. He had some APR, no?
Sir, he had iatrogenic injury following ureterolithotomy, sir, left side, which was iatrogenic in nature, for which he had colostomy, sir. And then he landed up with intestinal obstruction twice, sir, in the past.
So he had a recent history of weakness, that maybe some neurological elements, maybe they're related to the spine, sudden weakness. Why he had a sudden weakness? Because any other psychological problem or any other problem that is not any history suggests of such type of problems. So consolidately, it is either a BEP, bladder outlet obstruction secondary to the BEP oblique malignant prostatic enlargement, with or without stone, with UTI, with diabetes, with probably he may have stricture. So these are the tentative or probably last down the line neurogenic bladder. So these are the some probable diagnosis you may encounter. So in exam, if someone asks the question like this, you have to give the diagnosis and you have to give the cause also, why you are suspecting this diagnosis.
Yes.
Sir, how to prioritize the differential diagnosis, sir, on the basis of history?
देखो, what I feel as a first diagnosis is he had voiding symptoms for 1 year.
Yes, sir.
Dribbling since 1 month.
Yes, sir.
Then probably hematuria and fever. So bladder outlet obstruction initially. It probably end up into the acute urinary retention. As acute urinary retention, then infection, fever, hematuria, that can be explained, and dribbling overflow incontinence. Associated diabetes as a predisposing factor for causing the retention. So this is the sequence fitting into the probable that diagnosis. But what is there after examination only you can able to know that what is there exactly inside.
Right, sir.
Okay.
Coming to the examination, on general examination, patient is lethargic and drowsy, but patient is arousable. Pulse rate is 80 per minute, regular and rhythmic. Blood pressure is 130 by 80 in right arm in supine position. Respiratory rate is 20 per minute. Patient is afebrile at the time of examination. Saturation is 98% on room air. There is no evidence of pallor, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema, or spinal tenderness.
Okay, just stop here, Paras. So, Abhishek, this
Yes,
is the journal exam. Now, what you want to know?
Sir, I would want to do a systemic and a local examination, sir. Sir, yes, sir, systemic and a local examination I would want to do.
Yes, Amit, just systemic. What you want to know?
Sir, in systemic examination, sir, he has had surgery in the past, sir. And first of all, I would like to evaluate the suprapubic region, sir. And then, sir, he has had surgeries in the past, sir. So, sir, for that, I would want to do a examination of the abdomen. Genital examination, sir, I would like to do as a part of for sir to rule out meatus stenosis or sir phimosis, and DRE also would like to do, sir, to find out the status of the prostate, sir, if there is any lesion on the prostate or not, sir.
Anal tone, perianal.
And yes, sir, focused neurological examination also. Yes, sir.
And patient is drowsy. You don't want to do any neurological examination?
Yes, sir, focused neurological examine. Other than that, sir, neurological. Brief.
So what are the causes of drowsy in this case you are thinking of?
So drowsiness in this patient can be caused, say he's a 65-year-old male, sir, and sir, this can probably be because of obstructive uropathy, sir, azotemia causing drowsiness, sir. It can be because of electrolyte imbalance, sir, and may also be because of, sir, any lesion, sir, any neurological component, sir.
Like
TIA or something.
Yes, sir, stroke or lesion in the brain.
He is also diabetic.
Yes, sir.
Diabetic neuropathy.
Diabetic neuropathy, where it causes peripheral
Will not
neuropathy.
cause drowsiness.
So,
any specific neurological lesion, sir?
or it can be because of hypoglycemia.
Hypoglycemia, yes, sir, overdose of anti-diabetic, sir.
Or it can be because of multiple infarcts in the brain.
Yes, sir.
So then you have to elaborate. Okay. So, okay, Paras, go ahead. Just tell them. First, just show them the figure. Yes. Abhishek, you want to comment?
Yes, sir. So,
Want to describe?
Yes, sir. Sir, on the examination of the abdomen, sir, on inspection, sir, there appears to be, sir, a huge lump in the abdomen, sir, occupying the suprapubic region and the, sir, both sir, hypogastric and both, yes, sir. And sir, the overlying skin appears wrinkled and thinned out, sir, with areas of pigmentation, sir. Sir, the contours of bowel loops can be appreciated on the lump, sir. So most probably, sir, this can be an incisional hernia of the previous surgery. And other than that, sir, the genital examination, sir, the penis appears normal. He's an uncircumcised male, sir. penis scrotum appears normal. There is a 20 French 3-way catheter in situ, sir, and the urine in which appears to be clear, sir. Other than that,
Which type of catheter is there and what are the tubes there?
sir, 3-way latex catheter has been 3-way 20 French latex catheter has been inserted, sir, and the urine in which appears to be clear, sir.
And there is another tube also.
One is irrigation.
So his irrigation is going on, na?
I could not see, sir. I could not. Okay, yes, sir. Irrigation is going on. Okay, yes, sir.
So he has given the history, na? Patient had he was catheterized for clot evacuation and the
Yes.
clots were removed, and that is why we have started this irrigation. And 300 cc of urine was removed. Fine. Amit, you want to add anything?
I want to DRE examination finding.
No, on this inspection or something you want to talk? You want to add anything?
No, sir.
Okay. Paras, go ahead.
Per abdomen examination, patient was examined in supine position with exposure from nipple to knee in an adequate lit room. On inspection, abdomen is protuberant, umbilicus is central but it is displaced downward. A midline laparotony scar is seen. Large abdominal wall defect with thinned out overlying skin with underlying visible bowel loop peristalsis seen in hypogastric, umbilical, and right iliac fossa region. On palpation, no local rise of temperature. Abdomen is non-tender. Abdominal wall defect about 20 into 15 centimeter with palpable bowel loop is in the above mentioned region with positive cuff impulse seen. Other hernial site are intact. On percussion, there is tympanic note over the abdomen, normal liver dullness span. On auscultation, normal bowel sound present. Examination of genitalia and digital rectal examination. Under genitalia, uncircumcised patient is having uncircumcised penis with retractile preputial skin. External urethral meatus is normal. Bilateral testes and spermatic cord are normal on palpation. On DRE, no anal fissure, fistula, tag, or hemorrhoid. Anal tone is decreased. Non-tender, perineal sensation are intact. Cremasteric and bulbocavernous reflex are present. Prostate grade 2 enlargement, soft to firm in consistency, smooth surface, no nodule palpable, and rectal mucosa over the prostate is mobile. There is fecal staining of finger. There is no blood staining of the finger.
Yes. So this is a examination. So Abhishek, now next what is, you want to change your differential diagnosis or anything? You want to add anything?
No, sir.
Amit?
Sir, I want to put neurogenic bladder second one, sir, because of there is a tenderness over the spine and anal tone is decreased. First is bladder outflow obstruction due to enlargement of prostate, benign or malignant. Second one is neurogenic bladder. Third, stricture is ruled out because of the 20 French catheter.
Yes,
Is
Fine. Pankaj bhai, you want to ask something? Or we just go ahead? Hite sir. Hiren has joined or no?
Yes, sir.
Yeah. Okay. Fine. So Abhishek, now what you want to do now?
Sir, want to do some preliminary investigations for the patient, sir.
Pardon?
I would want to do some investigations for the patients. I would like to investigate the patient, sir.
So what are the things, basic thing you want to do?
Yes, sir. Sir, starting with the blood investigations, sir, in the form of CBC, serum creatinine, serum electrolytes, sir. And sir, urine routine urine routine examination, urine culture sensitivity, and an ultrasound of the KUB region, sir.
Okay, fine. Paras, just show them whatever they have asked.
Urine routine and microscopy. The pH of urine is 7, protein is 3+, sugar is absent, ketone is absent, RPC are 25 to 30 per high power field, WBC are innumerable, cast is absent, crystals are absent, and bacteria is present. On culture and sensitivity, the organism identified as Proteus mirabilis, 1 lakh colony forming unit per ml are seen. It is sensitive to amoxicillin, piperacillin, ceftriaxone, cefoperazone, meropenem, and amikacin. On general blood reports, the hemoglobin is 12.2. The total leukocyte count is 13,850. The platelet count are 3,58,000. Differential leukocyte count, neutrophil are 83%, lymphocyte is 13, eosinophils are 0, and monocyte are 4. The sodium of serum sodium of patient is 115, potassium is 4.5, fluoride levels are 82. The serum creatinine of the patient at the time of admission is 2.8. INR is 1.09. TSH and PSA are normal. They are 1.98 and 1.09 respectively. The total calcium is 8.29. Uric acid level is 5.5. LFT is normal, and the glycosylated hemoglobin of the patient is 8.9.
Amit, what are the information? Can you just summarize what are the most important information you are getting from this?
The patient is hyponatremic with uncontrolled blood sugar and increased WBC count. So patient is in the sepsis, sir.
So also he is uremic and sir, yes sir, he is also uremic. Creat is 2.8 sir, and UTI is also present sir. Total counts are high and urine routine is suggestive of innumerable WBCs.
Okay. What about ultrasonography?
On ultrasonography, both the kidneys are normal in size and shape and ecotexture. The urinary bladder is well distended and show multiple peripherally echogenic lamellar lesions within, largest measuring 8 cm. Associated with mobile echogenic hyperdensities, likely clots are also seen. Prostate is normal in size and ecotexture, no evidence of calcification. There is bilateral moderate hydronephrosis.
Yes, Abhishek.
Yes sir. Sir, the ultrasound is suggestive of a bilateral moderate hydronephrosis and also finding suggestive of calculi in the bladder, sir. So I would do the preliminary investigation of an X-ray KUB, sir, to find out the status of the bladder calculi, sir, and any other calculus if it is there in the urinary system, sir. First of all, and sir, it is also there are also bladder clots. It also has a history of hematuria, sir. So I'd eventually do a at least a non-contrast CT scan for this patient, sir, because his creat is high, sir, right now. So initially, sir, yes, sir. Initially, I would do X-ray KUB, and sir, then later on, sir, non-contrast CT.
Okay. Amit, you want to add anything?
No, sir.
Okay. Amit, what you can see?
Sir, this is the X-ray of pelvis showing it is overexposed and bone appears to be normal, and there is no such calcified structure in the area of the bladder, sir.
Someone has asked about Euroflow, but he is on catheter.
Patient is on catheter, yes, sir.
And bowel loops are seen with the gaseous distension in whole lower pelvis and below the pubic symphysis.
Yeah. Is it going to make any difference? Amit?
It is most probably soft stone or less calcified stone.
Or a radiolucent stone.
Or radiolucent stone.
Okay, fine. So he has asked for a CT. So what type of CT we have done, Paras?
Yeah.
I think creatinine had decreased by that time.
Yeah. In the initial treatment of the patient was admitted in ICU and the vital parameter was stabilized. Dyselectrolemia was corrected. Patient was catheterized, bladder wash was given, and clot were evacuated. And the irrigation was started using a tri-way catheter. Pathological and radiological investigation was further done to achieve the diagnosis. Patient TLC came down to 8800 and serum creatinine was reduced to 1.48. CT scan was done. These are the films for CT.
Just see all the films, Amit and Abhishek, and
Yes,
then
sir.
you talk on everything. Okay. In the exam also, you always tell them if they only one film is shown, tell them that I like to see all the films. Okay.
Yes, sir. Um, sir, on the axial and the coronal cuts of the CT scans, the solid organs can be seen. And sir, there is an obvious incisional hernia that can be seen, sir, which is occupying the lower abdomen, sir. And a part of the bladder is also encroaching into the incisional hernia, sir. Inside the bladder, sir, we can appreciate the Foley's bulb and, sir, areas of calcification, sir. Yes, sir. Areas of calcification. Other than that, sir, no obvious mass can be appreciable, sir. No obvious. Yes, sir.
Bladder wall is smooth and
Yes. Bladder wall appears smooth and does not appear thickened, sir.
What about kidneys and other thing you said?
Sir, I haven't seen the film, sir.
Then you tell them now.
Yes,
You
sir.
see all the films and then you comment. Amit,
just a bilateral hydronephrosis is seen with the thinning of the bilateral renal parenchyma.
again,
Yes.
see, I am telling you, all of both of you, just see it properly. Give 2 minutes. See all the films and then you tell us in detail.
Sir, enhancement of the parenchyma on both sides can be seen, sir, and also right-sided hydronephrosis can be seen, and significant thinning of the parenchyma on the left side can be seen, sir.
Okay. Go ahead.
And yes, sir. And sir, is there a excretory phase?
No, these are the only films. Yeah.
Okay.
Okay.
So yes, sir. Sir, ureters I cannot comment upon, sir. Bladder, like I mentioned, sir, a part of the bladder is encroaching into the incisional hernia. Other than that, the Foley's bulb can be seen, and areas of calcification can be seen. The bladder wall appears smooth and does not appear thickened. And other than that, sir, yes, sir, the kidneys are on the right side. Hydronephrosis is present. Both kidneys are enhancing, sir. Right-sided hydronephrosis is present, and sir, on left side there is significant thinning of parenchyma can be seen, sir.
Okay, Paras, just read the report.
On the CT report, both the kidney appear normal in size and show evidence of scarring and small cysts. Bilateral hydroureteronephrosis is seen. Both the ureter are tortuous. The urinary bladder is markedly distended. Multiple laminated, calcified, and non-calcified calculi and cast are seen within the lumen of the urinary bladder. The largest calculus, which appears partly calcified, measures 8.6 into 5 centimeter. Enhancing membranes are also seen within the lumen of the urinary bladder. Cystoscopy is suggested for further management. Large anterolateral abdominal wall hernia is seen is also seen. It contains loop of bowel, large bowel, omental fat, vasculature, and a part of urinary bladder.
Fine. Dr. Gite, you are there? Dr. Gite?
Yes, sir. I am there, sir. Listening.
Now this is you want to ask them question about now further.
Yeah, so it is a huge distended bladder with multiple ring-like calcification and a soft calculus also. So what they are planning. Abhishek, what is your plan? How you are going to plan this patient?
Sir, sir, I would like to counsel the patient, sir, explain the condition to the patient, sir, and condition and the findings of investigations to the patient, sir, and then counsel him for cystoscopy first, sir, with and explaining him the possibility of bladder stone, sir, which may require management, and sir, management and subsequent management of the incisional hernia also, sir. And then after explaining the patient the possible the options of surgery and the risks involved, sir, I would proceed with the cystoscopy, sir. Cystoscopy and cystolithotripsy, sir.
Now let me tell you, incisional hernia, even the big time surgeons, no surgeon wants to touch it. Everyone has said that because the very big defect, it's a multiple adhesions, 2-time intestinal obstruction also they have not opened him up because they feel that if they will open up, there will be multiple perforations and this patient will not survive. So no one wants to touch. Last 10 years or 12 years, he is just like this.
Abhishek,
so, sir, if he is, yes, sir.
Up to doing a cystoscopy, I will agree that can be defended. After doing the cystoscopy, you have to remove the clots, whatever clots inside. You have to check it out. Is there any hidden mass behind the clots? Then considering the size of the stone, that is near about 8 centimeter, I think.
Yes,
8.25.
So 8 centimeter stone, if it is there, and that is not totally calcified, is soft stone. So you are planning cystolithotripsy. So I am worried.
And there are multiple stone, only the largest is 8 centimeter.
So because
so the options available in front of you are for any bladder stone, including adult as well as pediatric, is lithotripsy, then cystolithotripsy, then percutaneous cystolithotripsy, that is PCCL, then open surgery, and then cystolitholipexy. So these are the few described options for bladder
Pankaj
stone.
is there? Dr. Pankaj Maheshwari.
Yes, I am there.
See, I just wanted to tell you that we are not able to even go above the symphysis pubis. This all intestines, everything is coming below that, and there is no way to do a suprapubic any procedure. That is what I realize on this patient.
Sir, if Pankaj sir is remembering, we have just done PCCL for such type of patients recently.
No, but the intestine is coming even distal to even the symphysis pubis. Means there is no way you
Agreed,
can
sir.
separate out intestine. That is a problem.
Means
if I go suprapubically, I have to go through intestine only.
In front of you only there are two options. One is open surgery with due risk, and another is PCCL, because considering the size of the stone, the cystolithotrypsy I feel cannot work, as it is soft stone also. For PCCL, if you are thinking the bowel will come inside, then you have to search the window using the ultrasound. Then you have to mark that site, and you have to puncture the bladder using the ultrasound, and you have to dilate the tract and to go for the PCCL. That bladder is highly distended. Part of the bladder is inside that hernia also in CT scan. So if you able to avoid the bowel and go inside the bladder with ultrasound guidance, then that will be the best minimal invasive treatment for such type of stone, because PCCL can be done for such type of stones. Theoretically speaking, if you are going for the stone which is more than 4 centimeter, open surgery is better. For 2 to 4 centimeter stone, PCCL, and then less than 2 centimeter stone, either it is a cystolithotrypsy or ESW. So that's what's various literature and guidelines is saying.
Yeah.
So here we have only two options. One is open surgery and another is PCCL, if the track is possible using the guidance.
Fine. Okay.
Pankaj sir, you can add anything.
Yes, I would agree with what you have said. Can we just see the CT images again? How are the bowel relation to?
So please show the CT scan.
Yes, sir.
Yes, so there is bowel in front of the bladder, and I would agree with you, sir, that finding a window may be difficult. I also agree with Dr. Gite that with such large stones, PCCL probably is the best way to tackle this, because open surgery is going to be extremely practically impossible. And but Gita sir, आप भी देखिए तो the bowel is really stuck all over the anterior wall in front of the bladder. So probably finding a window will really be difficult.
Agreed, sir.
Can we see now the cystoscopy?
Yeah.
Yeah.
Sir, if you just check at exactly the level of symphysis pubis.
Yes, the low down it is usually possible. I agree with you.
No, but I'm not able to go above the symphysis pubis also. On
Okay, sir. Sir, we both are agreeing with the problem what you are explaining, but that will be the better idea to, if it is possible. Yeah. Otherwise you have to go for open surgery with whatever due risk.
Correct. Just show the cystoscopy, beta. Paras.
Yes.
31 number. Yeah.
Recording in progress.
Appear to be mucoid stones.
Yes, sir.
This is a situation. So instead of doing putting an implant sheet from abdomen, I thought, why can't we try it from below? So what I did was, I took a stitch on either side of implant, put a guide wire, and on that with a dilator, I introduced implants, as you can see. Now with the nephroscope, I tried to use a lithoclast. It was just like in a cotton. It was just going inside, not breaking it. Then with the laser, I tried to, the
only way to treat mucoid stone is break it with forceps and pull it out.
Yeah. So the third thing that we did was with the nephroscope, we started, breaking the stone, and we did it to some extent. But the best thing was to aspirate with the Tommy syringe. So after
So if-
breaking it,
So
we just-
if you use the suction
suction
or
also
such
we
type of
use
stone, if
with
already
the
we
suction.
have placed
So,
the amplage inside,
so
So
four things we did. We use the lithoclast, we use the laser, then with the forceps and with the suction, and ultimately we use a Tommy syringe. And just show the next one.
Yes.
Paras? No, the stone. Yeah. No, that stone. Ah. So first time we could remove with a big ball full of stone, this type of metric stone fragments. Still 2 stones were remaining inside. So again, after 48 hours, we did the same thing. Show the next one. So this is the second time we did it. Okay, now the next thing is Abhishek.
Yes,
Now,
sir.
how long you will keep the catheter and how will you manage now? Now the stone is out. Everything is clear. Now what you will do?
sir, how difficult it is to place the amplage in male urethra?
In this case, because the urethra was quite, petrolous and smooth and everything was okay, we could put it. Otherwise, it is very difficult.
What size
Yes,
amplage
yes.
sheet did you put in, sir?
That was apna ye normal 26 and 27, that is, and this thing nephroscope was 24.
Okay.
Sir, Gite sir, one question, sir.
Ji.
Sir, if we go ahead with an open surgery, sir, how do we deal with the hernia defect, sir? How do we deal with the hernia, sir?
If you are going for open surgery, you have to deal everything.
Yes, sir.
That hernia, that bowel, if it is rigidly stuck, you have to resect it. So सब कुछ करना पड़ेगा. It's like supramajor surgery.
Yes.
And definitely it will end up into some resection, small or large amount.
True.
Yes, sir.
So now,
Okay, sir.
Abhishek, this is a part of the story. We have
Yes, sir.
removed the stone. Now, how will you go about?
Sir, this gentleman also had a neurological component, sir. I would like to evaluate that neurological component.
No,
by
he's
doing-
now everything is fine. He's moving around. His electrolytes are normal. Everything is normal.
Yes, sir. Sir, he has a dribbling of urine, sir. He had dribbling of urine, and yes, sir.
At that
Also,
time, he had a dribbling of urine, but he had a retention overflow. 300 cc. Apart from this was removed. He had a clots inside. We have removed the clots, and now we have removed the stone also. Now you tell us how to go about.
sir, I would want to evaluate the neurological status of this patient, sir, by doing an urodynamic study, sir.
Okay. You don't want to remove the Foley's catheter and see? Suppose if he passes urine well, then?
If he passes urine, then it is okay, sir.
So then what do you want to do?
Sir, give him a catheter-free trial, sir.
Amit, what is your view?
Yes, sir. I will first give him a catheter-free trial, and if patient doesn't pass, then I will go ahead with the UDS.
Okay, then after 48 hours, this patient had a little weakness of the lower limb. He was not able to, like he was not able to walk properly. Otherwise, he was, every day he used to move around. Now,
For both of you, I've got one question.
yeah.
A patient who is already in chronic retention has developed bilateral hydronephrosis because of bladder outlet obstruction. How will a trial of catheter removal help? Means, is it
No.
really indicated to
So,
give a trial?
I will place it by another way. If bladder outlet obstruction with bilateral hydronephrosis is there is a roll-up, trial without catheter.
Precisely. That's the question.
Abhishek, answer
Sir,
karo.
yes, sir, because there is bladder outlet obstruction, sir, the bilateral hydronephrosis may be caused by that bladder outlet obstruction. So, sir, we need to rule out the cause of that obstruction, sir.
So precisely, if the obstruction is so severe to cause bilateral hydronephrosis, then do you think he will be managed conservatively?
Not likely, sir.
No, sir.
Not,
So-
not
Why
likely.
is it without catheter?
Abhishek, my question is bilateral hydronephrosis can be because of the stone also or not?
Stone causing bladder outlet obstruction. Yes, sir, it can be.
No, bilateral
देखो,
hydronephrosis. If the patient has got a
passing-
large stone, can it give rise to bilateral hydronephrosis?
Yes, sir. But
Sir,
Yes, sir.
Sir, it can end up into bilateral hydronephrosis, but
Yes,
already
sir.
it is overstretched bladder for long duration. Then it is a large size stone that remembering the contractibility of bladder for with a short duration is really it is difficult. So passing up already hydronephrosis, so it is ideal indication for some surgical intervention. Then better to not to give a trial. Go for some investigation, then localize the problem and treat the problem. That's what ideally one should go for. The
Now,
chances of passing.
another thing is just see the cystoscopy. There is hardly any trabeculation. Just so.
I saw that, sir. Even there is no significant bladder outlet obstruction also seen there.
Yeah.
So I definitely feel, sir, ki if patient had a bladder outlet obstruction with bilateral hydronephrosis, we usually in last 5-7 years we have not given trial to any single patient.
So, you see, let's not put it to this patient, but theoretically speaking, a bladder outlet obstruction with bilateral hydronephrosis or chronic retention would be an indication for surgical intervention.
Surgical, correct.
Now, in this patient, I agree that there is no significant bladder outlet obstruction. So more so, I feel, sir, that it is important we do a urodynamics to find out what's happening to the bladder.
Agreed.
Fine. So after 48 hours, this patient had some problem. So we did the MRI. Can you show the MRI?
MRI films are not available. The MRI findings were areas of altered signal intensity in the frontoparietal, periventricular, and subcorticular deep white matter, suggestive of ischemic etiology, with lacunar infarction in the right lentiform nucleus and left corona radiator. And there is a decreased flow in P4 and P5 segment of both the posterior cerebral artery.
Right. So as you said very rightly, we did actually, I'll tell you what I did. I thought that I will like to give him a catheter-free trial. I gave him a catheter-free trial, but he could not pass urine. He went into painless urinary retention. Almost 1 liter of urine was removed and he was recatheterized. And now we have done urodynamic study. Paras, show them. So I totally agree with Dr. Gite and Dr. Maheshwari on that point that if the patient has got chronic retention and he has got bilateral hydronephrosis, then we don't have to give him catheter-free trial. At the same time, this patient, again, he has got no trabeculation and still he has got bilateral hydronephrosis, hydroureter retention and diabetes mellitus. In both the ways, I think urodynamic study is important and catheter-free trial is not indicated. Okay, fine. Anyone can? Abhishek? Amit? Paras?
Yes, sir.
Show another.
Yeah.
Any one of you want to comment? Abhishek?
Sir, the detrusor appears to be unstable, sir. In filling phase only it is showing. Yes, sir. In filling phase only it is showing, sir, instability, sir. Although there is no leak or anything as such, sir. But yes, sir, the detrusor appears little bit non-compliant and unstable, sir.
Okay. Anyway, Paras, just read the
Yeah.
report.
These are the pressures.
Report nahi diya?
Yes.
Yeah.
Bladder capacity is 500 ml. Proprioception is delayed. Compliance is high. Urethral closure mechanism is normal. Detrusor is acontractile. Sphincter is decentralized and deinnervated. There is neurogenic vesico-urethral dysfunction.
So this is the report. Amit, what you will like to do now?
Sir, here I am dealing with neurogenic bladder. So I will advise patient or patient's relative to do a regular CISC
Okay.
to keep the bladder empty.
Yes, sir. He's a 65-year-old gentleman, sir. So regular CIS is the best we can offer him, sir.
गीते सर, आपका अभी फाइनल सब कुछ बता दो.
Sir, already what one should do is place the catheter for near about 2 to 4 weeks. Reassess the upper tract status, that hydronephrosis is gone or not. Then teach the self-clean intermittent catheterization, what students were telling us that is right way. If he is able to do it properly without any problem, because doing a CIC at the age of 65, if it is, and with having some neurological diseases at brain level, so hand-eye coordination, and there are a lot of things which is not possible to do it for such type of patients. So CIC is not easy job. So what we usually doing in such type of patient is place the catheter for near about month, reassess with sonography, serum creatinine, urine routine culture, low dose suppressive antibiotic, and we will give option for as he is requiring long-term catheterization, that may be theoretically not looking good, but SPC oblique periurethral catheterization, and preferably SPC.
Maheshwari ji.
Which can be changed at home with relatives, by relatives, sorry.
I agree, sir. Means the first option will be CIC. Theoretically, second option SPC. In this patient, again, because of his incisional hernia and ball position, SPC may be awkward. So CIC oblique long-term catheter would be my treatment option.
Fine. So Abhishek,
Yes.
what are the indications of doing urodynamic study?
Sir, indications of doing urodynamic
So
studies.
when you will do it, urodynamic, I'm not talking only of now, we are not talking only of these patients. Okay. So when the
Yes.
patient comes to you with a retention of urine, in which cases you will like to do urodynamic study?
So chronic retention of urine associated with diabetes, sir, significant post-void residue, sir. Sir, any bladder outlet obstruction, sir, enlarged prostate, sir. Then, sir, any neurological component if present, sir. Any spinal surgery, spinal trauma if present, sir.
Very
high flow Qmax, sir, associated with
Yes. Less than 50 years of age or more than 80 years.
Yes, sir.
exactly. See, why don't
Extremes
you
of
say
age.
young patient, middle age, and old age? So in suppose a young patient, less than 40, 45, 40 years patient comes, I think in all the patients who are young and get the retention of urine, you must do urodynamic study.
Yes, also failed previous surgery, sir. Someone mentioned.
Then 45, 50 to 65. When you
Yes.
will do urodynamic study?
With the high PVR, or is there any neurological component like spinal?
I'll tell you that patient has got high PVR, no problem. He is passing urine, he has no diabetes, he has got no neurological complaint. He is 55 years old. He has got an enlarged prostate. Will you like to do urodynamic study?
Yes, sir.
Yes, sir. 55-year-old enlarged prostate, sir. And
Bladder contractility, sir.
yes.
If bladder is contractile or it is
He is passing urine. He is passing 100 cc, 150 cc.
but he is not completely, sir, emptying his bladder.
Yeah, so that is because of obstruction. But when he is passing urine means his bladder is contracting. And there is no underlying any neurological problem. So basically, then according to you people, all the patients whom you are planning to do surgery, you are going to do urodynamic study.
No, sir. No, sir. Not every patient, sir. Sir, specifically patients with previous history of retention, sir, or chronic retention with diabetes, or sir, any patients with any spinal or neurological components.
So neurological. So there's literature says that less than 45 you should do for all patients. 45 to 65, basically when the patient has got some neurological disorder, like as you said, diabetes, peripheral neuropathy,
Yes.
Yeah. So transverse myelitis, any history of that, Guillain-Barré syndrome in past. So all these things you must go ahead. And more than 65, even if they don't have all these 65 or 70, they don't have all these underlying comorbidities, still you do it. For the reason is you want to find out contractibility and how many days you are planning to keep the catheter.
Yes.
So you both the reasons. So this is what one of the paper had mentioned. Okay.
Right.
Fine. Okay. So now, yeah, Gite sir, any further questions? You please go ahead.
No, sir. No, sir.
Yeah, no, you just to finish this clinic. Any question related to bladder outlet obstruction or these stones? You want to go ahead?
Sir, usually in such type of patient, why may go to the management only. If patient had a large prostate and large stone, a small prostate and small stone, large prostate and small stone. So how that management will differ? Can it be done in one sitting? In which type of patient it can be done in one sitting? So what are the ways of doing the TRP? That is, if it is large, then whole plus cystolithotripsy, TRP plus cystolithotripsy, TRP plus PCCL. Permutation combination that particular helpful for that particular patient. Student should be able to identify that and he should be able to answer in exam. That is that on that particular day, which type of patient it will come, because if it is 20 gram prostate and some 3 centimeter stone, both can be tackled in one sitting by cystolithotripsy and TYP/TRP. If it is 100 gram prostate and 2 centimeter stone, whole plus same sitting
Sir,
with the same.
why don't you give
cystolithotripsy.
Gite sir,
Also sir,
एक
large
situation
stone,
देते जाओ ना. Gite sir, आप एक situation देते
large stone, there may be some role for Freyr's prostatectomy also. Large stone and large prostate.
Agreed,
Yes.
sir. Agreed.
Yes.
Agreed.
So, Dr. Gite, what I am suggesting, you start giving them one situation and let them answer.
Sorry.
Let them answer in two lines, na? They can just answer.
Okay. If simple is a large prostate and large stone. So what are the options available? So already sir has told it is open surgery. Open surgery is one.
Surgery, sir. We can deal with the prostate and the stone in the same sitting, sir.
Okay. What are the options available?
Or laparoscopic or robotic assisted that
Laparoscopic oblique robotic transvesical Freyr's prostatectomy stone removal. Another option. Okay. Next.
stage procedure.
Stage TURP plus stone removal, sir.
Very good. One time prostate with HOLEP or one time HOLEP plus stone. Pankaj sir. Both, if it is large also, can it be done?
Definitely, that is an option. Yes, you could do a PCCL followed by HOLEP.
Agreed, sir. So so you have to tell the answer as per the exam, from which place examiner is coming, what he want, his choices. थोड़ा सा change करके बताना पड़ेगा. लेकिन these are the probable options. Small stone and small prostate.
एक ही suggestion है. Don't start with robotic. Let
Agreed.
be the last option.
Ideal option for large stone, large prostate is open surgery and staged. Stage option, open surgery, stage, then HOLEP if you are having, and then lastly laparoscopic oblique robotic.
Yes.
So if it is a small prostate and small stone, conventional TRP plus cystolithotripsy. Small prostate and very large stone, 6 centimeter stone.
PCCL plus TURP, sir.
TIP.
So
TYP or TURP.
it can be done with stage procedure also. Just one time PCCL, wait for some time, give some alpha blocker. If it is passing the urine, then TYP can be avoided. If it is not passing the urine, then go ahead with TYP in second sitting. That is another option. Then मेरे ख्याल से small prostate and small stone. वो हो गया. Large prostate, large stone हो गया. Large prostate and small stone.
Stage TURP plus
100 gram prostate.
yes, the stage TURP plus
The whole lab.
or whole lab, sir.
स्टेज टीआरपी का कंसेप्ट यूजुअली बहुत जगह पे कुछ लोगों को पसंद है नहीं है, तो मुझे लगता है कि ओपन सर्जरी फॉलोड बाय होलेप, दोनों भी कंपैरेटिवली एग्जामिनर का ये देख के बताने का, होलेप प्राइमरी फर्स्ट भी बोल सकते या सेकंड भी बोल सकते. तो ओपन सर्जरी, होलेप एंड इन सेम सिटिंग दैट स्मॉल स्टोन कैन बी टैकल्ड.
Yes, sir.
एंड और कुछ ऑप्शन है क्या, ऐसा पूछ रहे थे, फिर स्टेज सर्जरी.
Okay.
सो ऐसा ही सर इतना ही रहता है यूजुअली. स्मॉल शॉर्ट केस रहते हैं ब्लैडर स्टोन रहा भी.
Good, sir. A very, very nice case. Such large leukoid stones is very interesting.
And it was, I think it was little difficult surgically. So I thought that, the students will, when they start their practice and when they come across such cases, I mean, this is in like last 32 years, 34 years, first time I came across.
And you know, even that, in
4-5 days, I was only in dilemma how I'm going to deal with it. Luckily, it could, I could manage it.
For a implant sheet to be placed in the Indian urethra is also very interesting. There is a case report on this in British Journal of Urology. I think it is way back in, I think, early 90s. Mein hai sir ek case report where they had put an implant sheet to repair a ruptured bladder, but an implant sheet to remove mucoid stones is very interesting. Implant sheet has been very commonly used in female urethra, but male urethra mein there is only, I found one case report where they had put it for repair of ruptured bladder.
Yeah.
That is why, sir, that nephroscope, the older nephroscope used to have that outer sheath. So that sometimes can help, sir, to give wash and all. So when you use the outer sheath of the nephroscope, we can attach the tubing syringe as well as give washes.
And so Hiren, that was almost, I think, 28 French.
No, sir, but now the newer wolf scopes are coming, no, sir. Yeah. They also have a provision of outer sheath.
Outer sheath. Yes, yes.
Yes, sir. Yes.
Correct.
Someone has placed down that ULTOA group, the removal of bladder clot with suction machine. And he has finished the clot in 30 minutes using the endoscopic oblique ultrasound guide.
So, Dr. Gite sir, I recently got, I think I had suggested this paper to you for review. I had suggested you as a reviewer for this paper, where they had used the morcellator suction to remove bladder clots. And it works very well. Means I have tried it on a couple of occasions. It works very beautiful.
So वो thing इसमें try कर सकते थे शायद मेरे ख्याल से.
Mucoid stone में बिल्कुल try कर सकते थे. Just उसमें मुझे एक ही दिक्कत था कि there were few calcific areas which would not have come with your morcellator. Yes.
Yeah, and but that it may not be available everywhere. Na? If you have got lasers, if you are regularly doing, then it's okay. So the only thing was that in implant with this 2 thread, so that it doesn't go away inside. Because if it goes away, because the implant is not more than, the longest is 20 centimeters. And urethra, if it is longer than that, it will be very difficult. So that is why we have kept these 2 threads to pull it out.
Excellent, sir. इसका साहब एक छोटा वीडियो बनवाइए.
Okay. आपका और गीते सर का थोड़ा एडवाइस लेके we'll make it and do a good presentation.
जैसा विषय देखे.
Yeah.
Pankaj sir, last time that 2 ureteric catheter literally works very well.
Yeah, that was a fabulous idea, Doctor. That was a wonderful idea.
I just I say I idea to kar diya. Literally, it is large volume stone and it is 2-hour job only.
So what I was doing up till now was putting the ureteric catheter above the stone first. And once you come to ureteric stone, then pull that catheter down. But keeping one catheter up and down is a wonderful idea. And
Next time,
especially
sir.
in your patient, putting 2 catheters was quite comfortable.
तो नेक्स्ट टाइम मेरे ख्याल से डिस्कशन को रखते हो केस सो दैट कि
चलेगा।
अलग अलग टेक्निक भी थोड़ा बेनिफिट हो जाएगा.
So what I suggest that we keep 2 or 3 cases, so half an hour and 1.5 hour.
छोटा डिस्कशन सर.
Similar
एक्चुअली
yeah,
क्या है कि
three cases.
we are making them ready for ward round and short cases at present.
Fine. So any suggestions, please tell us before we close down our first clinic. Students, any suggestions, please put it on this chat.
They can directly suggest, sir, no issue, because this whole program is only made for the students.
For them only.
So whatever they want, we are ready to deliver it.
Yeah, and another thing is, I think now the group can be of more than 500 members. So we will reduce our, instead of 3 groups, we'll make it 2. One of the last 2 groups, containing 500 students, and one group which I think they have already passed. So we'll keep them separate. Correct? Okay. Chalo, thank you very much.
Thank you, sir.
Yeah.
Okay,
Thank
so
you,
nice,
sir. Thank you, Gaurang Shah, sir. Thank you, Gite, sir. Thank you, Maheshwari, sir. Thank you, Hiren Sodha, sir.
Yeah.
good. Well done.
Thank you, sir.
Thank you, sir.
Bye, sir. Good night, sir.
Good night.
Good night, sir. Good night, teachers.
Good night, sir.